Hello everyone. Let's talk about fetal heart rate patterns today. First, we'll understand the uterine contraction. So this is the beginning of the uterine contraction and it is called increment. This is the decreasing or going away uterine contraction, that is decrement. And this is the peak time where the contraction is at its highest. So this is increment, that's the beginning of the contraction. This is peak, and this is the time when contraction is decreasing. Once contraction is ended, then there is relaxation time, and relaxation time is very important because when contraction is present, fetal heart rate are decreased, and when there is relaxation time, fetal heart rate comes to normal because they start getting perfusion back. Then this is about the graph, and this graph is called cardiotocography. And at bottom, these are the uterine contraction, and on the top, these are the FHR. Okay. So in 10-minute strip, the normal uterine contractions are between 3 to 4. In 10-minute strip, the uterine contractions are between 3 to 4. So 3 to 4 contraction in 10 minutes of strip is normal. And how we are going to count this 10-minute strip? So between this red line, this duration is of 1 minute. Okay, between this red line, this is of 1 minute of time period. So in 10 minutes of time period, if contractions are between 3 to 4, like 1, 2 and 3, if they are 3 to 4, they are normal. But if they are 5 or more than 5, then this is abnormal, and it is called uterine tachysystole. And so we do have one example here. Here, there is another CTG strip. And if we count the duration, 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. This is a 10-minute time period. And if you can see here, 1, 2, 3, 4, 5, 6, 7 are the uterine contraction. And what we said, 5 or more than 5 are called tachysystole, and it's abnormal, non-reassuring, and that causes fetal hypoxia because uterus does not get time in between to perfuse a fetus, and so fetus does not have enough oxygen. Then the baseline fetal heart rate. What is baseline fetal heart rate? So this is how you will see the graph where at bottom there are uterine contraction and there are fetal heart rate on the top. And if you can see here, these are the irregular fetal heart rate activity. This is called variability. And this is very reassuring. Reassuring means it's normal. Okay, reassuring word. What that means is normal fetal heart rate. It's a good thing. So to have the variability in the fetal heart rate, it's a good thing. Okay. Now in simple term, if I explain to you, variability is ups and downs in the fetal heart rate. Okay, and variability occurs as a result of the interaction between the chemoreceptors, baroreceptors, nervous system, and connection with the cardiac responsiveness. Meaning, whenever fetus need or there is increased oxygen demand, the heart rate is increasing. The heart is responding to it. So it's a good thing. Okay, so these upward spikes are called acceleration. We'll discuss this acceleration in more detail, but these are acceleration, and the downward deflections are deceleration. So right now, when you have to count the baseline fetal heart rate, you have to ignore this acceleration and deceleration. What you need to do is you have to observe the fetal heart rate activity for 10 minutes of time period, and you have to notice that where these fetal heart rate are located, most of the fetal heart rate. Okay, ignore this upward peak or downward peak, but most of the time, on an average, where they are located. So in this, it's somewhere around 120. So 120 is the baseline. And then, as I said, variability is a good thing. And we do have different type of variabilities. If variability is absent, then it's a problem. There is a problem because I said variability is a good thing. Now, if these spikes are not detected, then it is absent variability. There are little bit variations like up to 5 beats per minute or fewer, then it is called minimal variation. And if variability is up to 6 to 25 beats per minute, you can see these spikes here. that is moderate, and there is remarkable spikes, ups and downs, then and again, if it is more than 25 bits per minute, then it is marked variability. We do have another image to understand it better. So in this picture, you can see here it's kind of straight line, no variability, that is absent variability. There are little bit variations here, but not much, so minimal. And if you can see here, there are more variations, moderate, and here there is marked variations, you can see here. So that is called marked. So we do have absent, minimal, moderate, and marked variability. Now, which one is normal and which one is abnormal? So if there is absent variability, then it is worrisome. It's concerning. That could be because of acidosis, anemia, hypoxia, or neurological trauma. If it is between 5 to 25, like minimal to moderate, then it is good or reassuring. So you have to document it. No actions are needed. And if it is between, or if it is more than 25 bits per minute, then it is marked variability, and sometimes it is good, sometimes it is bad, depending upon the cause. If the fetus is doing well, then sometimes fetal might have marked variability, or sometimes if there is maternal infection, fetal infection going on, or if there is hypoxia, then marked variability can also be present. So absent is worrisome, actions are needed. Minimal and moderate is good, reassuring, no actions are needed, and marked variability depends on the cause. Then we are going to understand these terms, acceleration and deceleration, what we discussed in variability, and these are the different type of fetal heart rate. So let's talk about acceleration. Acceleration is abrupt increase in the baseline fetal heart rate. We just talked about the baseline fetal heart rate, average fetal heart rate, and the normal fetal heart rate is between 110 to 160 beats per minute. So on an average, if the baseline fetal heart rate is 120 for any fetus, and if there is increase of the fetal heart rate abruptly, all of a sudden, if the heart rate is increasing to 15 beats per minute, what that means is, let's say if it is increasing up to 135, so if there is increase of 15 beats per minute at least for 15 seconds, then it is called acceleration, and it's a good thing, it's a good sign. It is called reassuring FHR pattern. Reassuring. So here in this picture, you can see these are the uterine contraction, and here on FHR site, when you are monitoring, you can find out the baseline first. So somewhere here it's a baseline, and whatever spikes you are seeing here, abrupt increase in the heart rate, is called acceleration. It's called acceleration, and it is because of fetal movement or any kind of environmental stimuli. The fetal heart rate can be increased. Then we have deceleration. So deceleration is abrupt decreased. All of a sudden the heart rate is decreased, that is for 15 beats per minute, then the baseline, and at least lasting for 15 seconds. So that is called deceleration. So acceleration is increase in the fetal heart rate for 15 beats per minute above the baseline, lasting for at least 15 seconds, whereas deceleration is decrease in the fetal heart rate less than the baseline for 15 beats per minute, lasting for at least 15 seconds. That is deceleration. We do have different kind of deceleration. One is early deceleration, late deceleration, and variable deceleration. So let's talk about this deceleration in more detail here. So this is early deceleration, and early deceleration occurs because of head compression, or because of increased intracranial pressure. And this is reassuring, meaning no actions are needed. If it just change the mother's position, then the fetal head compression can be taken off. So no major actions are needed. You just need to change the positions of the mother, and this one will go away. So how you will find out if there is early deceleration going on? So what you need to do is, when contraction is starting, you have to draw one imaginary line, okay? And you have to see here the FHR also starts decreasing. Early deceleration starts when uterine contraction begins, and it recovers or come back to normal when uterine contraction stops. So here somewhere uterine contraction stopped. So you can see here the FHR came back to normal. came back to normal. This is another example of early deceleration. So you can draw one imaginary line at the beginning of the uterine contraction. So you can see here this FHR started decreasing. Okay, and it is at peak level at its lowest, where the uterine contraction is also at peak level. And when the uterine contraction is ending, the fetal heart rate came to normal. This is early deceleration. Okay, it is called reassuring type of fetal heart rate pattern. You just need to change the position of the mother and it will go away. Okay. Then we do have late deceleration. So late deceleration is because of uteroplacental insufficiency, and that could be because of mother's hypotension, or if there is preeclampsia present, or there is uterine hyperstimulation. Okay, uterine tetany. So these all reasons can cause late deceleration, and it starts at the beginning of the peak of the uterine contraction and recover after the contraction ends. When the uterine contraction is at peak line, that time you will start noticing decreased in the FHR. One more time, what I'm saying is when the uterine contraction is at peak level, the FHR start decreasing. When the uterine contraction is ended or ending, that time the lowest point will be there. That means nadir will occur, and then slowly the heart rate will come up. Okay, so basically it comes up, the heart rate will come back to normal after contraction ends. After contraction ends. This is another picture of late deceleration, where you can see here the uterine contraction started from here, and this is the peak, and at the peak time we were observing the FHR activity here, and you can see here there is no movement at all, and after that there is some decrease in the FHR from here. And when uterine contraction is already ended, that time the FHR is at nadir. That means it's at lowest point. That is because of the uteroplacental insufficiency. What interventions we can take? Oxytocin is being administered, then we need to discontinue oxytocin because it causes uterine tetany. And then we have to perform LOIN. And what it is, you have to change the mother's position to left lateral position. Oxygen you need to give, IV fluids, and you have to notify to healthcare provider, because this is non-reassuring type of pattern, non-reassuring. So what is variable deceleration? So variable deceleration meaning there is no association with uterine contraction, or even if sometimes uterine contraction association is present, the recovery time is different, meaning anytime there can be deflection or deceleration, and anytime the heart rate can come up. So there is no association with uterine contraction. This occurs because of umbilical cord prolapse or umbilical cord compression. And to treat this, we need to perform push position method. So we are going to talk about that in next slide. Then we do have prolonged deceleration. Now, what is prolonged deceleration is, so if it lasts between 2 to 3 minutes, it is called non-reassuring pattern. Okay, and if it is lasting for more than 3 minutes, then it is completely abnormal. So prolonged deceleration meaning is just that it's lasting longer. So here we do have one graph, and you can see here there is continuous downward deflection. The heart rate are continuously decreasing, and that is for long period of time, and then slowly it start coming back up. So this is prolonged deceleration. For long period of time, there is deceleration going on. We do also have one more abnormal, non-reassuring variation or variability, we can say, sinusoidal pattern. And in sinusoidal pattern, it's very rare type of pattern, but whenever it occurs, it is associated with fetal mortality. It's very abnormal, and it occurs because of fetal hypoxia, fetal anemia, or hemorrhage. And you can see here in this graph there is oscillating pattern, meaning it goes up down, and the shape, it is also called as sine wave. Okay, sine wave. And there is no variability, meaning it doesn't go like this. Okay, it doesn't go like this. So there is no variability, and there are no acceleration present, and it is because of hypoxia. Okay, non-reassuring fetal heart rate pattern. Definitely actions are needed. Definitely intensive interventions are needed for this. Then we do have fetal tachycardia. Fetal tachycardia is the baseline heart rate greater than 160 lasting for 10 minutes or more. We are not talking about acceleration here. Acceleration was for short period of time where there was increase in fetal heart rate above the baseline for 15 beats per minute at least for 15 seconds. This one is tachycardia where continuously for more than 10 minutes the heart rate is remaining above the 160 beats per minute. That is tachycardia, and there are many reasons for it. Maybe because of hypoxia, infection, hyperthyroidism, anemia, fetal tachyarrhythmia, or infection, maternal infection. Then we do have fetal bradycardia. So fetal bradycardia is a fetal heart rate, baseline fetal heart rate less than 110 lasting for 10 minutes or more. So it is not deceleration. Deceleration was for short period of time and we learned different variations in that. This is bradycardia where the heart rate are less than 110 and that is lasting for more than 10 minutes. That could be because of epidural or spinal anesthesia which is used during the time of labor, or in maternal seizures the fetal heart rate will remain low. And in some of the cases, bradycardia is okay, is normal. But if bradycardia is present with variability, then it is a good sign. Even if the heart rates are low, but there is variability is present, that means heart is fine, the nervous system is fine, it's a good sign. But if fetal bradycardia is present and there is no variability, or if there is late deceleration, then it would be non-reassuring. Okay. So in general, if I have to talk about early deceleration, late deceleration, and variable deceleration, then this is how we can draw. So let's say this is uterine contraction. If I say early deceleration, so early deceleration means what? It's the beginning of the uterine, at beginning of the uterine contraction, the fetal heart rate also start decreasing and is at peak nadir, where the uterine contraction is at peak level. That time there is nadir. Okay, and then as contraction goes away, the fetal heart rate will come back to normal. This is early deceleration. When I'm talking about the late deceleration, what that means, when the contraction is at peak, that time the fetal heart rate will start decreasing, and when the contraction is ending, that time it's at peak level and then it will come back up. And variable deceleration means there is no connection. Anytime it can go up and anytime it can go down. Okay, so that is variable deceleration. So here we do have few more information about the all different kind of FHR divided into category 1, 2, and 3. So these are the type 1 or category 1, we can say like moderate variability or baseline heart rate like between 160, 110 to 160, early deceleration or acceleration, or if there is just the deceleration but no late or no variable, then it is considered as a normal and no interventions are needed. No interventions are needed. If there is minimal or marked variability, if there is tachycardia, prolonged deceleration, bradycardia with variability, recurrent variable deceleration with minimal or moderate variability, no acceleration after stimulation, then these are considered as abnormal with unexpected outcomes. Sometimes there can be good prognosis, sometimes it can be bad prognosis. So it requires monitoring. Re-evaluation should be done. Okay, so this is category 2. And then we do have category 3, where sinusoidal pattern are there, absent variability, persistent bradycardia, recurrent late deceleration or recurrent variable deceleration. So late deceleration and variable deceleration, these are abnormal and definitely some resuscitative interventions are needed, or we also need to prepare for C-section. Okay, so in short, we do have one mnemonic to remember, will chop. So V as in variable deceleration, C, and that occurs because of the cord compression. Okay, we can remember will chop and these are associated with this. So variable deceleration, V as in variable deceleration, and that is because of the cord compression. E as an early deceleration, that is because of head compression. A means acceleration and that is okay, and L means late deceleration and that is because of placental insufficiency. Now early deceleration, that was because of head compression, but we learned that it is reassuring heart rate pattern. That means You just need to change the position of the mother and heart rate will be fine. If there are acceleration present, that is just okay. No actions are needed. Then this one is abnormal and this one is abnormal. So if there is variable deceleration is present, that is because of cord compression. Then what we need to do? Push position we need to do. Push position. So what we are going to do is, let me show you one picture here. So that is because of cord compression, right? So there is cord prolapse. You can see here the blue cord which is protruding out, and that is compressed by the fetal head here, and that compression by fetal head is causing variable deceleration. So what we are going to do with the gloved finger, we are going to push the fetal head up. That is called push. And after pushing the fetal head up, we want to change the position of the mother to take off this pressure. Okay, so either you can choose knee chest position. This is called knee chest position. Either you can use modified Sims position, or either you can give Trendle leg bug position to mother. So these are the different position that you can give to mother to take the pressure off of the umbilical cord. Okay, so that is for cord compression. And when there is late deceleration is present, so that is because of placental insufficiency. And what we need to do for that, we need to do LOIN. And please remember one important point for your exam. If in the question they say that oxytocin is being administered to the mother who is in labor and nurse is monitoring the fetal heart rate, it shows late deceleration, what interventions will be taken by the nurse? So if there is late deceleration, it is because of placental insufficiency. So the first thing you need to do is you need to discontinue oxytocin, because oxytocin causes uterine tetany, strong uterine contraction, and because of that there is decreased placental perfusion. Okay, and so fetus is in distress, so you are going to discontinue oxytocin and then you are going to perform LOIN, which is position change, oxygen, IV fluid, and notifying to healthcare provider. And any of the abnormal fetal heart rate pattern, please understand, we can perform LOIN, changing position of the mother, oxygen, IV fluid, and notifying healthcare provider. And please remember, if oxytocin is being administered, then the first thing that you are going to do is discontinue oxytocin and then perform LOIN. Here is the end of the review. If you have any question, you can write in the comment. Thank you.